Vinod Prasad will be speaking about the update with Bluebird Bio's gene therapy.
Hey, well, thank you very much, everybody, for being here this afternoon, sitting through the day's proceedings. Everybody is wide awake and looking forward to another round of talks this afternoon. So thank you very much. I want to, before I proceed, thank ALD Connect and Kathleen and her whole team for inviting us, as well as for putting this ALD Connect meeting year after year for last 10 years. I understand this is the 10 years anniversary. And selflessly connecting the experts and the patients in a room so they can talk openly and clearly and without any judgment. So kudos to you and thank you very much. It's been a treat for me all of this morning, listening to all the talks. But I think the most rewarding for me was listening to the patient's perspective. And I want to thank you for being so open and courageous and really opening your heart out and share your experiences so we as physicians or ones who have some expertise in some aspect of this can really truly appreciate what you're going through. So thank you very much. And then the young investigators. Oh my God. I am so impressed with all of your presentations, and I think you have bright future in clinical and laboratory investigations. So congratulations to you. To me, it seems like I'm here for a family reunion. Not only because, not in my family, we don't stand up and start giving lectures to each other when we have family reunion. But the reason it feels like a family reunion to me is that I see so many familiar faces. I've had the honor and privilege of taking care of many of the patients whose families and the patients are here in the room. And it really has been one of the most rewarding experiences for me. I was also here about 4 years ago speaking on advances in umbilical cord blood transplant, which I have done for many, many years before started in a new role, and I'll talk a little bit about it. So we've been caring for patients with ALD or adrenoleukodystrophy for a very long time. I've had, in my 20 plus years of taking care of patients with ALD and similar diseases, there are two kinds of heartbreaks that I have seen and felt. The first one is when a patient came to us with a diagnosis, not only ALD, but many other diagnoses, similar diagnoses, that could be really treated effectively with transplantation, but we could not do a transplant because the disease was too advanced. And that's very difficult to get over, that here is a patient, here is a treatment that could be effective, but the disease is too advanced and we could not do anything about it. Well, someone did something about it. And there is one person I want to particularly recognize, and that's Elisa Seeger, whose son happened to be one of my patients. And she took it upon herself. And how she does, I have no idea. But she's took it upon herself that she's going to do everything to bring about newborn screening to as many states as possible and to advance the field in a way that more and more children can get the treatment that they deserve and potentially could be made available to them. So thank you very much, Lisa. The second heartbreak is when you have a patient who gets treatment with transplant. You've done everything right. Everything is going very well. And then they develop some complication, life-threatening complication that hurts the organ, leads to organ failure, or in some cases, death. And that's the heartbreak, which again haunts me many times, is that everything that you could do to minimize the toxicity, you did, but there are limitations to various treatments that are available. And if there are things that can be done to improve the outcome by maintaining the efficacy or improving the efficacy, but at the same time try to decrease the toxicity, we should do everything that we can to advance that. And as I said, I've been doing transplants for 20 plus years. I was the director of transplant at Duke. But 3 months ago, I decided to make a switch. I still love my patients, so I'm still keeping a clinic at Duke. I'm still a professor at Duke. But I started working with Bluebird Bio in a full-time capacity to help with whatever expertise I have in trying to advance a treatment that has a potential to be less toxic than what is otherwise available. So I'm in a new role. I'm here to talk about gene therapy update because that was the task that was given to me. So I have a lot of disclosures. I'm an employee of Bluebird Bio. I own stocks in the company. I'm speaking on behalf of the employer, Bluebird Bio, and not in any other capacity. And we were invited to speak and give an update on Skysona or Elicel. So here is the current status of gene therapy. Skysona, also known as Elicel, received accelerated approval from FDA in September of 2022. Whenever a drug is approved by FDA, FDA releases a package insert, also known as prescribing information, which truly has all the information that we can discuss with the patients, with the families, with the physicians, and everything that you need to know about the drug is present in that package insert. And that package insert states in the blue box is Skysona is indicated to slow the progression of neurologic dysfunction in boys 4 to 17 years of age with early active cerebral adrenoleukodystrophy. The indication is approved under accelerated approval based on 24 months major disability-free survival. And I'll talk a little bit about that. It also provides limitations of use, which suggests that it may not be universally effective, that there are problems associated with it, and it should be clearly understood. And if a drug has significant toxicity, then it comes with a black box warning. And that black box warning for Skysona is shown here, which clearly states that there is a risk of hematological malignancy with this particular treatment. So how did we reach, or how did we get to FDA approval? It's been a long process. As you can see, the folks at Bluebird, with the help from a number of our investigators and clinical sites, as well as the patients and families, have been at it for more than a decade. Initially, we had to collect data on what is the outcome of patients who do not get any treatment or any definitive treatment, and that's in the top row. Initially, data was collected on the base on untreated patients, as well as some patients who had undergone transplantation. Subsequently, we and FDA realized that we need to have more contemporaneous data on what is the outcome of transplant patients with ALD who underwent transplant. So that led to the second study of data collection, that's the ALD 103. In the second row, there are two studies, the ALD 102, which was the first study that was undertaken almost 10 years ago, and that completed 32 patients were enrolled in that study, and it was followed by another study, a more definitive study that was ALD 104 that started at the end of 2019. And I am happy to say that that has also completed, and there were a total of 35 patients that were enrolled on it, and that study is undergoing analysis. So in total, 67 patients have been studied on these two protocols. And to make sure that we follow these patients not only for 24 months, which was the mandate of these two studies, that we are following these patients for another 13 years. So a total of 15 years, they are getting enrolled on long-term follow study, which is row number 3, which is the LTF 304, and that's the long-term follow study. And then because Elicel or Skysona has been FDA approved, these patients who are going to get commercial Skysona, we would like to follow them as well for 15-year period. So they will be enrolled or requested to be enrolled in the registry 502 study. So that's the clinical development program, which I think is really important for us to understand. So before I move further talking about the gene therapy, I also want to spend maybe 2 slides on talking about the other treatment that is available, which is the hematopoietic stem cell transplantation. So this is data from ALD 103 in the first row that I showed you, the more contemporaneous data. And this included 59 patients with, say, CALD who underwent transplant, and this data was collected retrospectively and prospectively. And on the right side here is their overall survival. These patients were divided into 2 categories. One was early stage disease, which is the ED, and the second is advanced disease, which is AD. And AD was if the LES score measure of MRI findings was more than 9, they were advanced. And you can see here, if you can see my arrow, that the survival outcomes, overall survival in those patients who had advanced disease was much worse than those who had early disease. The early disease were further divided into ED1 and ED2 on the basis of what their LES score was, less than 4, 4 or less than 4 or higher. And it seems that those outcomes were very similar. In addition, we also looked at what is known as MFT for free survival. So not only survival, but surviving without any major functional disability. And you all know that patients with ALD are likely to develop major functional disability without treatment, including blindness, inability to speak, and number of other inability to walk, and number of other things. So this is survival without MFT, and you can again see there is a significant difference between advanced and early stage disease, underscoring the fact that transplant work in if performed early course of the disease. But it also comes at some cost. And this is also data from 103. And you can see that depending on what is the donor source and overall here, that there are risk of acute graft versus host disease, chronic graft versus host disease, transplant related mortality that I had mentioned initially, and also some risk of graft failure. So that brings me to the gene therapy. Dr. Florian Eichler had shown this slide, which and a brilliant talk earlier today. Essentially, the patient's cells are collected. It's a very standard procedure, which has been in place for decades for developing, for performing transplant for different indications. So the cells are collected after giving uh, 1 or 2 combination of 2 drugs called GCSF for, and those cells, which are essentially the progenitor cells or the hematopoietic cells, they are then sent to manufacturing facility where these cells that are deficient, they are coming from patients, they're deficient in a particular gene and in a particular protein, and these cells are then transfused with a viral vector that has incorporated gene in it, and those cells then go through the process of um, release testing and cryopreservation. And then once we feel, or once the site was given an okay that these cells are ready and available, dates are set, and the patient received chemotherapy. And those were busulfan cytoxin or ALD 102, busulfan fludarabine, fairly standard medications that are used. patient. And after that, the patient was infused. And over a period of time, these cells, as we heard from Dr. Troyland's talk about the incorporation of these cells in the brain, engraftment in the brain, and the hope is that these cells will then produce the protein that is needed um, and, and help the patient. This is the same 102, 104 study going into the 304 study. So, for interest of time, I will skip. I've already told the number of patients who enrolled on these two. So, a little bit more information on these two studies: 32 patients in 102, 35 in 104, total 147. Their age, median age, was 6 years. On the first study, 7 years. So, very similar. Overall, 6. Their less score was 2, although it ranged from 1 to 9 in the 102 study, and again, median of 2, but the range was 1 to 7.5. These are very similar numbers between these two studies. Neurological function score was very low because we wanted to, for the study, the requirement was that the disease should be in an early stage, and these patients were followed for a period of time. And I'm happy to say that the longest follow up that we have so far is almost 9 years after the first treatment that was given. It could also be translated in another way into the patient years of follow up. So you look at the number of patients who have had this treatment, 67 patients, and for how many years they have been followed. And if you multiply that number together, it seems that overall we have 265.9 patient years of follow up on this, which I think is really important to keep in mind that there is a lot of follow up on these patients. Then let's look at some of the survival outcomes. This is taken from the package insert or the USPI that I was talking about, the label, so to speak, of Elicell. And if you look at the dark black line, is the survival. This is the MFT free survival, so major function disability free survival. Those who received Skysona had a better survival, and it goes up to 24 months here post therapy. And then those who were not treated did not have the same level of survival, even 2 years. And then looking at the comparison between Skysona and the allogenic transplant, those patients who received, and now there are three lines here. If I can show you this one, Skysona is the solid black line, and then you have the interrupted black line, which is the um, hematopoietic stem cell transplant from mismatched donors. And the third one, which is more of a grayish line, and that is the hematopoietic stem cell transplant from matched donors. And you can see that in this graph, these two lines, the patients who received gene therapy or Skysona and those who had received transplant from matched sibling almost overlap, while the outcomes of those patients who received transplant from mismatched donor was at a lower level compared to those two. So then, anytime you do a treatment, and I think any pill, any injection, any procedure, any major treatment like transplant or gene therapy is associated with complications. That's the eternal truth of medicine. There is no treatment that is without side effects. So this basically underlines that a single dose of Skysona was given in 67 patients with CALD. We looked at a lot of the different parameters of toxicity, and I'm going to talk about some of those. And the first one I'm going to mention is the hematologic signal. As was pointed out on the one of the early slides, that there is a risk of hematological malignancy. Some people will call myelodysplastic syndrome. It is one of the types of hematological malignancy. In simple word, blood cancer. So myelodysplastic syndrome, acute myeloid leukemia, these are all types of blood cancer. MDS or myelodysplastic syndrome is an earlier stage. So there is some risk, and this can develop between 14 to 7.5 years after treatment with gene therapy. And we have more update data. One of my tasks as I joined Bluebird Bio is to make sure that there is clarity, transparency, and a communication with the family, with treating physicians, that we are all on the same page, that we understand what the risks are. So, interim analysis was done more recently, which was presented by Dr. Eichler at the Vancouver meeting, and some of that data would be presented by Dr. Duncan soon after my talk. So because there is risk of hematological malignancy, we are monitoring these patients very closely by doing blood counts, which is a very simple test. Um, Most of us have had blood counts done, and it's a simple blood test, and that can be done frequently, twice a year, 3 times a year, 4 times a year, depending on what the situation is. Sometimes even more frequently. We are also looking at what is known as the integration site analysis to look at where this gene has incorporated into the genome and all of that. And sometimes you have to do a bone marrow aspirate and biopsy. So there is a plan for all of this to be done on a regular basis. And again, early diagnosis is really important because there is treatment for it. And as a transplanter, actually, I transplanted a patient for MDS even before I ever transplanted a patient for adrenal leukodystrophy. So certainly, Dr. Duncan's talk will have more details on some of the patients. But I underline here is that early diagnosis is important, monitoring is critical, and if there is any issue, of course, Bluebird has all the numbers and the contact information that is displayed here. I understand that this is being recorded, so these slides would be available. This information would be available for everybody. There is also some risk of infection in any patient who received chemotherapy. So we also saw some infections that are underlined here. There is, when you give chemotherapy and you wait for the donor derived cells in transplant or gene therapy modified cells in gene therapy to reconstitute the marrow, it takes some time. And sometimes one of the measures of recovery of bone marrow is the platelet recovery, and sometimes it takes longer. So we also underline that sometimes there could be delay in platelet engraftment after gene therapy. And then I want to switch gears. So I have given you an update on from our studies and from USPI, the label of what are the risks of different treatments. Now I want to think about this in the context of how a patient or a treating physician would want to think about this. There are two treatment options at the moment. One is allogenic transplant, and the second is gene therapy, both of which are available in different centers. The final decision for any given patient, whether it's going to be the allogenic transplant or gene therapy, will be made by the family and your treating physician on the basis of many different factors, including who the donor is there a donor available or not, whether the donor is able to donate or not, and many considerations. But as we think about this, we think about these specific therapies in the context of what specific side effects each comes with. And I highlight those side effects, um, at least some of those, the key considerations in this slide as you think about um, those decision making process. In another way, when you look at the risk benefit analysis, you think about these, and certainly MDS is a serious complication. I would not want to minimize that. Graft versus host disease is a serious complication of allogenic transplant, and I would not want to minimize that. But as we make these decisions, it's really, really important that we continue to monitor these patients on a regular basis. And what I'm really trying to show here is the bench, bedside. And now, there was a time when I started my fellowship, there was a bench and bedside, but now everything is on a computer. So I had to put a computer there. That we are looking at all the data at Bluebird Bio with the help of your treating physicians who are sharing all the information. And we are meeting on a regular basis, reviewing every patient's data, and then have an open conversation of where things are, how we can help. And so continuous monitoring is really, really important. I know that there is a lot of questions about what we are doing with the MDS cases, so I underline these here in terms of information and investigation. There is an independent data monitoring committee which is charged with the study of oversight, and we are required and we comply with the requirement of providing information about any major functional disability if a patient develops, or MDS, or any other serious adverse event that happens. That information is given to the data monitoring committee. We inform the investigators as well as the treating physicians at the activated qualified treatment center, as well as FDA, the regulatory authorities. We are required to inform them of any issues. And then the physicians are able to inform their patients according to their own institutional guidelines and, and their relationship with specific patients. Not every patient um, wants to get the information in the same way. Some want to sit down, some want to graph, some want that information is disseminated in the best way possible by their treating physicians. We are here to update the CALD community, and we provide, as I said, information updates to FDA on a regular basis. We are looking at trying to understand at a very deep level what are those factors that may be contributing to various risks associated with this treatment. And if there are factors that we can identify that are modifiable, we will consider modifying it. If there are factors that we identify that can be prevented, I would say that would be a good idea to do those kinds of things. We also are going to, in the process of convening a panel of external experts to discuss these cases, and we are doing constant communication with the clinicians. And so that brings me to, I don't know how many minutes I took, but it seemed like we had a nice conversation. And I want to thank everybody. But there are two groups of people that I want to thank in particular. The first one is all of you, patients and your families, not for putting trust in us as in the experts, but for going through with many times without full information, because nobody knows that information. Science doesn't know that information, but you put the trust and you move forward, and for inspiring us to continue to do. And the second, the Bluebird Bio family. I think some of those members of the Bluebird Bio family are here. They're scattered across the room. And if you don't mind, you can wave your hand, or you can blow kisses or give virtual hugs. But they are here. And I can tell you, the ALD community, that their heart beats for you. And their heart bleeds for you. And more on a personal level, I've never talked about this publicly ever. But I was inspired by Florian. When there is trauma and grief, you can either get very angry or frustrated and think that the world is against you, or you can convert it into empathy. I lost my brother when he was 11-year old. So here is my empathy for you. Thank you very much. I'll take questions.
Thank you, Dr. Prasad. Great talk. Anticipating a few questions here. So questions? Go there,
There's
and then
a
we'll go
hand
to
here.
you, Ben.
Thank you for your presentation. And you may need 10 or 20 more years to even be able to answer this question, but I'm just curious if you have an approximate incidence of the myoblastic malignancies following gene therapy or grafting.
Sure. So we have information. This is public information, and it was presented by Dr. Eichler at the recent Child Neurology Society meeting. Dr. Duncan actually is going to talk about that, and she's going to give the numbers and everything. So I'll just wait for that. You will have.
Okay. Question, have you guys totally given up on Europe? And if patients in Europe want to access the therapy, is there an option for them to come to the US?
Yes. So at the moment, Skysona is not available outside of the United States. And it is certainly possible for a patient from outside of the United States to get treatment. And the best way to think about it is that the patients can reach out to one of the centers that is performing gene therapy and then work with the team there to be able to get this treatment. And also, there is a website, and Susan is going to help me. The website, the Skysona website, that has a link to My Bluebird support. So My Bluebird support, and the families can contact Bluebird through there, and they will be able to provide them. I see a couple of hands.
Karen Harrison from Alex Leukodystrophy Charity. Ben, thank you very much for bringing that up about the UK. So I'm sure you're aware, but the NHS have recently agreed to fund Libmeldy for metachromatic leukodystrophy. So hopefully that's paving the way, and it would be great to be able to offer our families, you know, an alternative treatment to bone marrow transplant.
No, absolutely. And you probably don't know this, but I was in England. I trained in England for many years, and I know NHS very well, and so I'm very aware of that, and that's great. Any other? Okay, well,
Thank you so much, Dr.
thank you
Prasad.
very much.
Round of
Yeah.
applause. Thank you.